Hello, colleagues and friends, and welcome to this new PCR webinar dedicated to the treatment of a patient with a porcelain aorta, calcified severe aortic stenosis, and severe calcification of the left main. In the next 1 hour, we will address one of the most interesting issues in our modern interventional world, which is the treatment of these two pathologies associated, the aortic stenosis and the coronary artery disease. It is my pleasure to share this task today with two friends and very well-known colleagues, Dr. Petros Dardas from Thessaloniki in Greece, the St. Luke Hospital. Hello, Petros.
Hello.
And Dr. Beatriz Vaquerizo from Barcelona, Spain, Hospital del Mar. Hello, Beatriz.
Hello.
They are, I would say, two co-founders of the known Euro4C group that you may know, a group dedicated to the treatment of calcified and complex patients. And they have been pioneering the use of devices in this setting. And why not in the setting of aortic stenosis? Because I go quickly to the objectives of this meeting today, which is supported by an unrestricted grant from Medtronic. And it's about the treatment, indeed, of coronary artery disease in patients with aortic stenosis. When to treat it, why, whether to treat it or not, and how. Then, how to facilitate the access to coronary arteries after implantation of a transcatheter valve, and how to perform a complex PCI after you have done the valve. So with no further delay, I move to our next speaker. Petros, please, will explain us which is the relevance of this coexistence of CAD and aortic stenosis.
Hello, good afternoon from me. My name is Petros Dardas from St. Luke's Hospital, Thessaloniki, Greece, and I would like to thank everybody and personally Flavio for the very kind invitation to this exciting, actually, webinar. Now, what is the prevalence of coronary artery disease in patients with severe aortic stenosis undergoing TAVI? From various studies, it's around about 50%, but this percentage increases with age, and it may go up to 75 or even 80%. However, coronary revascularization in randomized clinical trials in these patients is represented in only 12% of the patients. And this is because patients with more complex coronary artery disease and higher syntax score are excluded from the randomized clinical trials. And we all know from various analyses and registries that the coronary artery disease is associated with higher mortality at 1 year after TAVI. However, is there benefit from revascularization? Well, this is not clear as yet, but according to a meta-analysis done by Coronary back in 2017, there is actually no benefit from revascularization. And there is another meta-analysis with 11 studies, more than 5,000 patients, and the questioning whether PCI prior to TAVI improves outcomes. And actually, 30-day mortality, 1 year mortality, and risk of myocardial infarction favors TAVI alone rather than TAVI and PCI. And the question is why data on the influence of coronary artery disease on outcome in patients undergoing TAVI are so conflicting. There are 4 reasons: sample size, different baseline criteria, aortic stenosis severity, and coronary artery disease severity. As we mentioned, patients with complex coronary artery disease got excluded from the randomized clinical trials. And what the guidelines say, actually, from recent European guidelines, PCI is evidence 2A, but level of evidence C for patients undergoing TAVI. If there is a stenosis, a proximal segment stenosis of more than 70%, but the guidelines don't clarify when to do PCI, before, during, or after TAVI.
Well, thank you, Petros. This is the evidence that you have reviewed for us. I'd like to hear about Bea, which is her point of view and her analysis of the literature when PCI is performed in these patients.
Okay, thank you, Flavio. I think an important question in each TAVI procedure planning is whether patients with coronary artery disease should undergo coronary revascularization. I think several observational and retrospective studies comparing TAVI versus TAVI and PCI in patients with CAT did not find any significant difference in terms of mortality. The activation trial was the first randomized trial to compare routine PCI versus medical treatment in patients affected by severe aortic stenosis and coronary artery disease undergoing TAVI. And they found similar rate of death and rehospitalization at 1 year in TAVI patients treated with PCI or managed conservatively. But it's important to note that left main or complex lesions were excluded from this trial, so they enroll single vessels and not suboptimal stenosis. And I think it's important also to know that in the group of PCI, there was a higher risk of bleeding. Here you can see the Kaplan-Meier curve, and you can see that there is no difference between PCI and not PCI in this subgroup of patients. The SURTAVI trial was the only randomized study to compare both cutaneous TAVI plus PCI and surgical SAVR plus CABG treatment strategies, also in non-complex coronary artery diseases, and they found at 2 years the same results. They don't find any significant difference in the primary endpoint. The similar results were found in the Observant study, that is an Italian registry, and a recent meta-analysis. So here in this slide, I want to show you that is the timing of PCI. In this study, they compare PCI before TAVI versus PCI with or after TAVI. And they don't find any differences in MACE results in that two group patients. You can see here the Kaplan-Meier curves. So the American guidelines recommend PCI before TAVI in case of left main disease or proximal coronary artery disease, despite the evidence. And European guidelines, they do similar. They don't recommend a specific timing for coronary vascularization, but they recommend PCI on major coronary arteries. Thank you.
Okay. Thank you, Bea. So there is an agreement in the data that Petros and you have shown. I mean, the benefits of vascularization are doubtful, despite the fact that the European and the American guidelines are recommended it with a rather strong level of recommendation, which is 2A, although the class of recommendation, although the level of evidence is very low, it's C, so there is no evidence. So I will afford now another issue, which is that of the high-risk PCI. This is a paper that we have just published from our experience that addresses exactly the timing of PCI, whether it should be rather performed before or after implanting the valve, which is one of the main issues we will discuss today. And we divided our population of patients with more than 1,000 cases of TAVI and more than 140 cases of PCI, whether it performed before or after. And we divided this in two groups: low-risk PCI and high-risk PCI. High-risk PCI mainly based on the analysis of angiography, which included left main severe disease and 3-vessel disease. These are all stable cases, okay? There is no acute coronary syndrome. And what you see is that the general incidence of death is 2.1 at 1 month, and it's less than 1% incidence of stroke at 1 month. But when we go into detail and we divide all the population among those having PCI before TAVI, the stroke rate is as high as 6.5, and the mortality is 4.4. While in the patients doing PCI after TAVI, this is 0. When we go to the smaller group, anyway, 32 cases of left main or 3-vessel disease performing PCI before TAVI, the stroke rate goes as high as more than 9%, and mortality as 6.2, compared to none in the patients that underwent PCI of the left main or 3 vessels after TAVI. Of course, this is limited by the single center experience and the small number of cases. But when we analyze large and randomized trials like the SUR-TAVI, what we find here is that the general incidence of death and MI of these intermediate risk patients in the SUR-TAVI, it's identical to ours. It's 3% composite of death and MI, and stroke, sorry. But when we analyze the small number of, anyway, 128, very similar to our experience, patients that underwent both TAVI and PCI, you see that the mortality and stroke rises to the double, 6.3. Indeed, mortality is 4.7, identical to ours, and stroke is 2.3. So there is something that is doing harm when patients perform both things, either simultaneously or this is not specified in the trial or in sequence. And my interpretation of that, the patient with severe aortic stenosis has a low cardiac index because of the damaged valve, the gradient, much of the energy of this left ventricle is staying inside the left ventricle and is not going into the circulation. So the lungs, the liver, the kidneys, the press LV function especially are hypoperfused. But after you remove the aortic stenosis, immediately after, the cardiac index will practically double, providing much better perfusion, especially to the brain and the kidneys, which are two end circulation organs. There are no collaterals. There are no other ways of getting blood. The LV function will work much better immediately. Kidney, brain, and lung perfusion will be much better. And this makes, in my opinion, the TAVI procedure and the coronary procedure much safer. Just to give you an example of what I mean, this is a paper we published last year comparing the renal function in patients undergoing concomitant TAVI first and PCI compared to those undergoing PCI before and then TAVI. And what you see, it's very striking. I mean, the incidence of CKD, of acute coronary injury, acute kidney injury, after contrast is much lower. It's comparable among patients doing concomitant or stage strategy if the valve is changed before. But if the patient received contrast before changing the valve, there is a much higher incidence, goes to over 30% of acute kidney injury. And on the other graph, what you see is that according to the GFR, of course, the lower the GFR, the higher the probability of developing acute kidney injury. But this is much higher in a strategy of staged procedures. While doing this concomitantly and doing the valve before, the drop of the renal function is much less than doing this sequentially if you give contrast before. I hope this is clear. Is one of the explanations we have to say that removing the aortic stenosis will certainly improve the circulation in the patient, and then anything you do afterwards in terms of intervention and in terms of the metabolism of the contrast media will be more benign. So now to explain how a patient like this can be performed, I will ask Petros to present the case of today.
Okay, thank you, Flavio. Now, we're going to show the case of today. It refers to a 76-year-old male who was fit before the incidents, suffering from severe aortic stenosis, and he's symptomatic for angina, worsening over the last few months, class 3, and also heart failure symptoms, class 2, over the last 6 months. His LV function was preserved, and his kidney function was relatively preserved. He was in sinus rhythm, and underlying ECG showed complete RBBB, which is an indicator of possible developing complete block during or after the TAVI procedure. He was a generalized atherosclerotic type of patient with previous bilateral carotid endarterectomies, and a recent Doppler ultrasound showed total occlusion of the left common carotid artery and total occlusion of the subclavian and left vertebral artery. And here's a picture. You can see the whole problem. You can see the heavily calcified aorta. You can see the porcelain aorta and the heavily calcified aortic valve. You can see the heavily calcified left coronary system. And on the stat picture of the aortic of the angiogram, you can see the severe distal left main stenosis. And if we go in more details, you can see the porcelain aorta, the total occlusion of the left common carotid artery and subclavian and left vertebral artery as well. And here in this picture, you can see severe LVOT calcification going down to the mitral aortic junction. And also you can see the subclavian occlusion and the massive left coronary artery calcification. And doing the sizing, his annular mean diameter was 22.4 centimeter. Valve area was 4.48. The coronary arteries were relatively high, more than 12 millimeter above the annulus. Also, there was significant calcification in the STJ. You can see that it's a porcelain aorta that's at that point with a relatively good diameter. And if you can see the femorals, there is no surprise that they're full of calcium. And on your left side, you can see the full vascular trunk of the patient who is heavily calcified. So a generalized atherosclerotic patient. And here is his angiogram. This was performed in a different hospital from where the TAVI was performed. They attempted from the right radial artery, but it showed severe disease of the anonymous trunk. And then they went from the femoral, which showed occlusion of a small non-dominant right coronary artery. And here is a picture of the left main and the left coronary artery. You can appreciate severe disease of the distal left main involving both ostia, Medina 1.1.1, and also you can appreciate the heavy calcification of the left main. Now then, the question is, how would you treat this patient? The valve first, the coronary first, and which valve? Balloon expandable, self-expandable, intraannular, or self-expandable supraannular? And I'm going to address this question to Beatrice first. Beatrice.
Thank you, Petros. I think in my center, we go first PCI. In case the patient became unstable, we do balloon aortic valvuloplasty, and we do the TAVI in a second time. And in that case, with severe calcification, we use a supraannular self-expandable valve.
Okay. Well, at this point, we have provided to our colleagues all the background, at least what we think is relevant to this case, and the real presentation of a case that has been. So we will see how we manage. But I think that we have time for discussion because there are many questions coming from our website, and this is something I want to remember to those who are participating, that you can link and make questions. And indeed, I have a practical one that I will try to address now to both of you. Ahmad Saran says, okay, you're saying that putting the valve is better and leaving the coronaries like this. But let's suppose you are a young operator and you're called the night to perform PCI in a patient who received a front catheter valve and did not get a stent in the coronary. Of course, this will be much more difficult. Which is your opinion on that? I'll start with Petros.
Well, this is something that we see more often these days. Patients with previous TAVI coming with severe coronary artery disease. And we'll explain later on some tips and tricks of how to engage. But I think everybody has to get the experience of how to go through and perform PCI through a TAVI valve. So I would do PCI no matter if there is a TAVI valve there.
I guess you will tell us some tips and tricks about how to do the PCI after valve.
Yes,
but we
later.
leave this at the end of the day. So Ahmad, stay there. We will come back to that. And Beatriz, do you think that it's really, I mean, performing a PCI before the TAVI is preventing that this patient at the long run will have a myocardial infarction?
I think we don't know. When I do this strategy, is for two reasons. The first one is because if I do a TAVI with a severe complex disease in the coronary artery, and I have a complication that sometimes happens during the TAVI, maybe I have a minor complication if I don't have the coronary arteries revascularized. And the second is because is the reality the cannulate the coronary arteries with a self-expanded valve and also with a sapient valve is more complex than when there is no valve. Maybe you have 10 is easier, but at this moment it's not easy. So for these two reasons, I would prefer to treat before. In the patient is unstable, I do balloon aortic valvuloplasty.
That's a good idea. So you do the left main before. If everything goes smoothly, you leave the patient, and then in a sequential procedure, you put the valve. Is that right? That's your approach, is it? In case something is doing not properly well, you would help this patient with aortic valvuloplasty. Okay, which means two vascular access, which means rapid pacing. And I mean, it would be better not to do that, but it's escape line. And after that, you do TAVI. This is your approach.
Yes. Yes, is that.
Okay. Now, let me go to a concept that I think it's very important to underline. In patients without symptoms and signs of acute coronary syndromes, the lesions that we find during the workup of the TAVI process are found by chance. I mean, if not because of the TAVI, this patient would never do a coronary angiogram. So what you find an important lesion, can be a proximal LAD, left main. So our colleague is saying, I would rather treat this lesion with a stent because I don't want to do that one day when he will have an infarction and there is a valve in between me and the coronary. I think this is a very important issue that we have to make clear to especially young colleagues. It's a totally, I would say, misled concept to take it for granted that the natural history of an asymptomatic plaque will be worse than the natural history of a stent. Actually, all what have been done in stable patients have demonstrated that medical therapy is at least equivalent to stenting. And of course, no trial has compared medical therapy with asymptomatic patients, which is the case of those coming to perform a TAVI. So why would you be worried about the risk of having infarction because you find occasionally a lesion on the LAD? Actually, the risk of having an infarction will be higher if you put a stent, rather if you leave an intermediate stenosis which has not been tested for ischemia. What do you think about this? Is it too conservative reasoning, or do you think it makes sense? Petros, go first.
Well, I totally agree with you. And actually, we have recently changed our approach to these patients. And we perform the TAVI first, especially if it's a complex coronary artery disease. And but I totally agree with you that if you have an intermediate middle AD stenosis or mid-right stenosis, then and the patient doesn't have symptoms from the stenosis, then of course there's no point in dealing with this stenosis. Sometimes the problem is that the patient may have angina, and you don't know whether angina comes from the aortic stenosis or comes from a mid-LAD stenosis. And then you're puzzled what to do. Okay.
Yeah.
So this is when you have to decide.
This is one of the questions. Christian Dan Popescu asked what to do in a patient who has angina as the leading symptoms. What would you do in your lab, Bea? Would you do functional testing, pressure wire, do the valve before, and then check whether he still has angina, or vice versa?
In my center, we only treat proximal, really severe lesions, left main, proximal lesions, right coronary artery proximal, but mid lesions, distal lesions, we left after TAVI implanted, because we think that FFR in that situation is not reliable, is not. I cannot trust FFR in that situation. There are several studies comparing before TAVI and after TAVI, and are different. So intermediate lesions, not severe lesions in the mid and distal part we don't touch before, only complex lesions in proximal left main parts before TAVI. We do that.
Okay, I have to tell you that we have done a lot of research on FFR and IFR in aortic stenosis. I agree with you that it's not reliable in aortic stenosis, but actually it is after you have removed the aortic stenosis. So measuring FFR and IFR after TAVI gives you very accurate, reliable decision making, because if you induce ischemia, this is a significant lesion. And if you don't, it is not. We have also done this study with perfusion myocardial scintigraphy, and we have exactly the same cutoff as patients without aortic stenosis. So this is another reason why, if you want to evaluate the importance of this lesion, you should first treat the aortic stenosis and then perform physiology. But okay, we are getting into the mind of those who are making the questions, and that was one of the questions from Janusz Bogdan, who asked what to do with the proximal LAD 50%. So Janusz, this is what we do. We first treat the valve, and then we do FFR and IFR. If you get significant values, probably you should treat this lesion, but we don't know yet. But this is the most rational thing we can do. But let's see. With the next slide, please, I ask the technicians to show the results of the pool we made when we present this case. More than 250 colleagues replied to this question. Porcelain aorta, calcified aortic valve, what goes first, the valve or the coronary? And as you can see, the main opinion, the most common opinion, is to treat the coronary, 72%, which is what Bea is saying, while only 28% of colleagues would go for the valve first. Bea, is this because of the concern of being able to engage the coronary after the valve, or is it because of the concern of having complications during TAVI because of the presence of coronary artery disease? Do you have some advices about how to avoid troubles with the valve and the coronary's alignment?
Yes, I think I'm going to show you. I think most of people and myself, we kind not afraid but concerned about the engagement of coronary ostia in patients with TAVI. And I think in that case with Medtronic help us with some tips and tricks. Because it's important to know in acute coronary syndrome, that means in unstable patients, the time for a PCI in TAVI is much long to cannulate coronaries in TAVI is much longer, and between 3 and 9% of patients, access can be impossible. So it's the reason that some operators prefer to do PCI before. And the main factors that influence engagement of coronary ostia in TAVI patients, in patients with TAVI, are three. Anatomical, that means the higher or greater height of the coronary arteries and the augmented width of the valsalva sinus are associated with easier coronary ostia engagement. And also the prosthesis, we know that the sapiens could be better more than self-offended valves. And the reason is because this balloon expandable, with the evolute and portico valve, they extend beyond coronary ostia, they are taller. And also procedural. If we implant the valve high, we also is worse for engagement the coronary arteries. And also the commissural orientation of transcatheter aortic valve is important. I'm going to show you the next slide, sorry. And the next one. I think it's important first to define the commissura alignment is to make coincidence the neo-commissure from TAVI prosthesis with the native commissures so as to avoid that commissural post be in front of the coronary osteo. That is important to know the definitions because for SAVR, this is always controlled, but for TAVI is uncontrolled. So since the commissural post may just go to in front of the coronary ostium, this make worse the cannulate the coronary artery. So that is important, the commissural alignment. So in that study, they show that orientated devolved delivery system, the flash port position to the 3, that means facing the patient left side, away from the operator. In 90% of the cases, the hat marker that you can see here in the image became in the outer curve. And when this hat marker became in the outer curve, in 80% of the cases, you can see the C-tap is orientated in the inner curve. When it happens, this post, that is the main post, the commissure post, became between the left and right coronary artery. So there is a really commissural alignment. And it is easy to perform this maneuver. So you can see here a good position. You can see here in the right of the 3-cast view, and the C-tap position usually is in the inner curve, the 3 view, and is quite anterior. And you can see the CT scan, the C-tap is between the left and the right coronary artery. And only with this maneuver, you can engage more easy the coronary artery. But it is true that in nearly 20% of the cases is not at this moment control this.
Okay, so you have given some indications. It's very important. Commissural alignment is very important, specifically in the self-expandable and supraannular valves. It makes things much easier. And so now it's time to go to the case. I mean, there are still several questions from our colleagues. I'd like to make it clear. There is another question from Uma saying, isn't it better to do the angioplasty before because it's easier? Dear Huma, this is of course the easiest thing to do, but doing the easiest doesn't mean that it's doing the best for the patient. So if you are treating a coronary just because it's easy, you have to think that you are treating the coronary because it's necessary. And if you have to treat it, you have to do it in the safest way for the patient. So let's see how we manage this complex case in Verona. Please show the next slide. And I will try to advance. Okay, we treat the valve first, of course. This is provocative. And which valve? We selected a self-expandable supraannular. And believe me, this is not because this is a Medtronic-sponsored webinar, but because in our practice, when we have a young patient with such a huge calcification of the ST junction and the mitral-aortic junction, we are a little bit feel more comfortable with self-expandable valves rather than with balloon expandable. So this valve fits perfectly a 29 Evolut Pro Plus. And why this valve? Well, this is a relatively young patient. He's 76. So we need a valve that at least for 10, 15 years will give him the opportunity of a second intervention. And this is the valve with the best hemodynamics shown at 8 years follow-up. It is even much better than surgical valves as shown in the motion trial at 8 years. Then, as I said, an extremely calcified aortic root, it's a dangerous aortic root with a certain relevant risk of fracture. And this risk is totally avoided if you don't do balloon dilatation. Of course, you don't have to do post-dilatation because the risk is there again. But with a self-expandable valve, this risk does not exist. And then, of course, the concomitants of the severe CAD, you need to be well aligned to suffer when you have to engage the coronaries. So this was the reasoning why we decided to select the self-expandable Evolut Pro Plus. You see that the access from the iliacs are not easy. We tried to cross first with the dilator and after with the valve. You know, it's a valve without an introducer. It goes sheetless. And then it went easily because it's a low-profile valve. And it went without the need for predilatation. And you can see that it's a very stiff wire. It's a Landert-Twist wire. And the intention was, as in every case, to pace, if necessary, from the LV wire. But at the time of the deployment, the patient that has a previous right bundle block went to total AV block. This is why you see at a certain point we have to implant a temporary pacemaker on the right ventricle. And why is that? Because we plan to perform the PCI immediately after the valve implantation. So what you see here is a femoral approach using the same we used to implant the valve with a 3.5 extra backup guiding catheter, 6 French, and using the 0.35 angiographic wire to open and close the curve of the extra backup catheter until you find the appropriate hole to go in front of the left main. We are not exactly selective, but this is not an issue because once you put the wires, the catheter will smoothly advance and become selective. And even if you are not selective, the catheter, which is sat on the wires of the valve, it's very stable. So as in any case of left main, especially if very calcified, we start with an IVUS run. So there is an IVUS run from the third to the left main, and then a second one from the LAD to the left main. And I think the images do not need too much comment. There is a huge amount of calcium in both vessels and the left main in what has been defined by Petros during the presentation of the angiogram as a Medina 111. So we decided not to get into too much detail of the procedure because the webinar is not dedicated to the procedure itself, but to the management, the strategy. You see, this is a pre-dilatation with non-compliant balloons, then with bigger balloons, and then is the stenting using a culotte technique. So again, we are not going to discuss about the stenting technique, but we want to show you that you can perform your PCI through the core valve in the same manner you would do without the core valve or without the aortic stenosis, but in a much safer hemodynamic condition because there is no obstruction to the left ventricle because there is no aortic stenosis anymore. So you see, performing simultaneous occlusion of the left main, the circ, and the LAD. We have put a third wire to protect the intermediate, but you don't have aortic stenosis anymore. This provides you a much better hemodynamic stability, which might not be the case if you are working in a severe aortic stenosis, especially if the patient is old and if the patient has a depressed LV function. So you take all your time, and the operator had all the time to re-perform an IVUS run to analyze the quality of this very important PCI. It's a PCI of the left main, so you have to make sure that the stents are well deployed. The films are not running well, but the operator decided that the stents were not perfectly deployed, and so there is a second kissing and a final pot of the proximal part of the LAD to try to optimize the result, just as you would do in a case of elective PCI of the left main without aortic stenosis. And now you can see in the upper right corner the much better images at this nice reconstruction of the carina after the culotte. Now it's very clear. And then, of course, there is a little bit asymmetric expansion of the stent because of the monster calcification of the left main, but the idea is very good. This is the best you can get in such a calcified vessel. Why do I stress the fact that you can perform this procedure like in a regular procedure? Because you don't have the aortic stenosis. What would be the consequence of having a low flow, or having an occlusion of the left main, or having an occlusion of their huge circumflex in a patient that still has the aortic stenosis? So I think this is the main reason we have to debate, because of course there is no single answer to this question, but it's whether to afford this complex PI with or without a severe obstruction to the left ventricular outflow tract. So I open this question to open the discussion, because I think this is one of the main drivers of this decision. So I will ask first, ladies first. So I will ask Bea, what do you think about the safety of performing this procedure with or without aortic stenosis? Does it make a difference, or do you think makes no difference?
I think first that really the orientation of your valve was really good. The post of the commissure were not in front of the coronary. You can see very well that the orientation is better and easier to cannulate. And also, I think the operator is an experienced operator, because they do very well. So it's not as everybody, as you said. In that case, maybe because you have left dominant, you have left main. In my case, probably I will do easy and undersized balloon aortic valvuloplasty, and in the same way PCI, and after that I do the TAVI. In that case, because it's left dominant, it's left main, so I prefer to open a little bit the valve, treat the patient, PCI, and then do the TAVI in a second time. I think you have a complication during this TAVI procedure. Maybe the patient could be unstable, and go fast to treat this is not easier. You can see positive and negative things in both sides, in my opinion.
Sorry, I hear a lot of noise. I don't know if someone has the open microphone. Now it's okay. Petros, there is a question from our colleagues, and this is dedicated to you as a very expert. Would you like to perform rotation in a lesion like this? And in that case, would you do rotablation before or after putting the valve?
Thank you very much for the question. Well, first of all, we need to clarify one thing, that we don't speak about acute coronary syndromes, okay? In these cases, if you have an acute myocardial infarction or a post-myocardial infarction, acute coronary syndrome, or a non-STEMI, you have to treat this patient first. Second, we don't speak about stable middle AD lesions. The remaining of the patients with coronary artery disease are complex patients, and are patients like your patient, I mean, patients with severe left main or severe ostial right coronary artery with severe calcification. So in these cases, you have to deal with these patients. You have to feel comfortable in performing PCI after TAVI. For the reasons that you explained, we need to make sure that we need all the tips and tricks of how to approach these patients. And for rotablation, We have shown in some cases that we can perform rotablation very safely after TAVI procedure. I'll explain during my next slides how to do that. But we have done this and we have performed rotablation very safely, because if you go and do rotablation in a left main or in a huge ostial right coronary artery before you implant the valve, the patient may die. Okay, this is clear.
Good. Now, I know you have some slides to show, but before we move to your slides, I want to answer. There are many questions. Some comes from our friend Darius Dudek, and it's similar to that of Christian Dan Popescu. They want to know why we don't mention the accurate neo as the valve with easier coronary access. Is there any difference among supraannular and intraannular valves? Who wants to address this question to Darius and Christian? Do you have experience with the valve, with the accurate neo or not? If not, I cannot ask.
I don't have experience. I know there's a paper that they facilitate the orientation of this valve to cannulate easier the coronary arteries. I think it's a good valve, but I'm not sure in that scenario with severe aortic valve calcification is the best valve. But for coronary cannulation, they told and the paper said that is one of the best valves.
I absolutely agree. I have experience with this valve. It's a very nice valve. It's very soft, very delicate. It has the lowest need of pacemaker rate because it's a very delicate valve. I agree. It's very easy to have coronary access, but I agree with you. In such a very calcified valve, I wouldn't trust a valve that it's very delicate. You need to pre-dilate, post-dilate, and even though you may have some residual gradient. So it is like everything. It's a very good valve for coronary access. It's probably not the best valve in this terribly calcified. So Darius and Christian, I hope you will agree with that. And then the difference in between supraannular and intraannular, Petros, regarding gradients in a young patient.
There is a difference actually, and supraannular gives better gradient. And we know from an ocean trial that the long-term results of supraannular valves are very, very good, especially in small annuli. So as you said, in this, it depends on the case. I mean, in a case like that with very severe calcification, definitely supraannular valve will do the job better, to my opinion.
Petros, it seems that the coronary access is one of the main concerns for those who need to perform the PCI before, disregarding if it is necessary or not. It's because you feel more comfortable having done the job. Can you give some advices to our young colleagues about how to do that?
Yes, of course. I think if we get inside the 78% people who replied do the PCI first on our poll, most of them would have fear of approaching the coronary arteries. And let us just say some tips and tricks. Can you have the slide, please? Thank you. Now, as we've seen so far, I think the worst in brackets valve in approaching the coronary arteries is the Evolut Pro Plus valve. And of course, as Beatrice said, the coronary alignment is one of the main issues when you anticipate, especially when you anticipate PCI in these patients. The other thing is the implantation depth. If you have a patient that you are going to perform PCI after that, you need to implant the valve a bit deeper because the skirt height of the Evolut Pro is 13 millimeter. So the implant should be at least 4 millimeter below the annular plane to ensure the skirt is not overlaying the coronary artery. So this is one thing. The other thing is the guide catheter requires back wall contact for maximal support, but the valve itself may constrain the catheter. That's why we need to use, to undersize our catheters. So we use half a size less in every catheter that we routinely use. And also we use guide extensions, liberal use of guide extensions, to explain to you why. So If we are not sure, especially in dilated aortas that were inside or outside of the skirt of the valve, then one good tip is to use a pigtail catheter and place the wire inside the LV, so we are sure that we're inside the skirt of the valve. Then use a guide catheter half a size, as I said before, half a size smaller than we normally use. Sometimes Zatkins 3.5 is good for the left coronary artery, but sometimes an extra backup catheter. The other thing I want to stress is that no need to try and engage the ostium of the coronary. We should use a soft wire and non-selectively wire the coronary artery. Just follow the flow of the blood towards the coronary artery. And then we get a microcatheter, we exchange to a more supportive wire. And after that, we try to engage the guide catheter. But sometimes this is not very easy. So we have liberal use of guide extension. I think the good player in this case is the guide extension, because guide extension doesn't create distortion to the tip and is more softer and it wouldn't dissect the coronary ostium. Whereas if we go and struggle with a guide catheter, then we may dissect. If we get inside the ostium, we may dissect the ostium. And sometimes a good tip is to put an anchoring balloon and softly advance the guide extension into the ostium. And we have sometimes cases where the guide catheter is outside the skirt of the valve and the guide extension is inside in the middle of the coronary artery. And then the best views to assess the coronary access for left coronary artery is the spider view. For right coronary artery is a steep LAO. Don't use LAO 30 or 40. Go to LAO 70. There you see the ostium better, and there you can cannulate the right coronary artery better. And the last advice is that I always perform diagnostic angiogram with guide catheter. If I anticipate PCI, don't take a diagnostic catheter, take a guide catheter. Thank you.
Thank you, Petros. Very, very simple practical points. I will try to address in the last 7 minutes we have questions coming from our colleagues. You, Bea, very, very briefly, are you concerned about the risk of having an entrapment of the rota bar through the walls of the valve, or this is something that never happens?
In my experience, it never happened. I only did once, and I use a guiding extension catheter to be safe. And I think it's a good thing to use that, but I don't think so. When you engage the coronary artery, is quite normal. Normal angioplasty is not different. The problem is not always happen that.
Yeah, I agree, because we have published the largest series available of rotablation after TAVI. You can find it in PubMed, and this is something that is not an issue. Of course, you should not rotate from the aorta to the coronaries, but when your guiding catheter is after the valve, nothing will happen. Petros, there is a question.
Sorry, can I just, sorry, Flavio. Yeah. Can I just add something on this, what Beatrice said, that when we do rotablation, what we use these days, we advance the guide extension and the rotabar together and block. We go through the struts of the valve with the guide extension, not with the guide catheter. And then we start rotablating inside the skirt towards the ostium and inside the catheter. So this is a very good trick to go with the guide extension and the rotabar together.
Yeah, this is especially in the right, where sometimes the cannulation is not selective through the core valve. With the left, it's easier to go with the guiding to the left main, and you go normally. Yeah, I was saying, Francesco Brown is making a short question, short answer. Do you consider using Impella as a protected PCI in a patient with aortic stenosis?
Me?
No.
Well, I would read the aortic stenosis first. And in my opinion, Beatrice has got a different opinion, but I don't like doing balloon valvuloplasty. If I have to spend time to do balloon valvuloplasty, I will just put the valve.
Okay.
I feel safer with this.
If the patient has such a bad LV function, I think that the safest way to do this procedure or to manage this patient, Francesco, is doing a balloon valvuloplasty. If the patient recovers LV function, then you can do the TAVI or you can do the PCI and then the TAVI. But putting an impeller, it's adding a lot of cost, it's adding a big sheet in the femoral. And of course, you can do that in cases of acute hemodynamic impairment, but in elective cases probably can be arguable. Well, we are reaching the end. Darius, who is a very expert operator, says that you can also access the coronaries going outside the valve. Yes, this is something we can do. Right. This is very specific. It's for very, let's say, high-class operators. Our webinar was more addressed to the general decision-making. So if I can have the last slides, I want to share with you a personal thought which has to do with the clinical management of these patients. You are concerned about the strategy of the valve first. Yes, we saw that, probably because you are worried about having complications during the procedure because of CAT. This is something that is not reported in the literature in stable patients, especially if they have good LV function. And in my personal experience of nearly 2,000 TAVIs, it never happens, not even after rapid patients. So this may happen in a patient with acute coronary syndrome or very, very low ejection fraction, but not in elective patients. And then the other point is because you are frightened not to be able to catheterize the coronaries. And we have shown you how to manage with that. First of all is vessel and coronary and valve alignment. But we have to underline the fact that this issue is very, very stressed because it's discussed in webinars, in congresses, in case reports. And it's true. If you don't train and you are not well trained, you may have problems. If there is no good coronary alignment and commissure alignment, there might be also the impossibility of getting there. So you have to think it before at the time of implantation. But there is an issue which is totally hidden in our culture and in our literature, which is the number of patients that encounter severe complications, including death or stroke, that are not being reported because they do not enter the TAVI registry. All the evidence that we have reviewed with you from the SUR-TAVI and all the meta-analysis show that there is an increased rate of death, stroke, and MI, and of course bleeding, if you do the PCI before the TAVI. And these are patients entered randomized trials or controlled studies like ours in Verona. But imagine how many patients are undergoing PCI in non-TAVI centers that have complications and are not published and are not even censored in registries. So we have to think about that because it might be a problem. I want to make this graphic. The real magnitude of the problem are the complications of the pre-TAVI PCI, which are not reported. There are no publications on that. If you have a complication, you tell it to your colleague, you experience this and you can share with your peers, but you will not publish that. And this is not published. And this is happening in referral centers, small centers, performing PCI that are not indicated, but acute coronary syndromes. Before TAVI, it's debatable. And as we have seen, maybe even harmful. What should be clear is that patients with acute coronary syndromes and aortic stenosis should do the artery first. All the rest is a matter of discussion. So with a minute for the last comment, I would like to give this minute 30 seconds to Petros and 30 to Bea for a last thought before we close.
Well, thank you very much. And I think that we have to make clear in our minds that performing PCI after TAVI is something that can be done. It may need some experience, but it can be done. And we have to clarify what is the spectrum of the disease. If you have severe coronary disease and severe aortic stenosis, I would personally treat the aortic stenosis first and then follow with the coronary artery disease.
Bea, some final comments before we close?
Yeah, Yeah, Flavia, I think you are very provocative in the good sense, but my thought is the companies need to improve the valve frame to cannulate easier. When you cannulate easier, there will be a problem.
That's very provocative too, but not to the colleagues, but to the companies. I think it's a very good request. So we had more questions. Unfortunately, 1 hour is too short. It's flown very quickly. I hope this has been useful. I thank you all those who have participated actively during the webinar. Absolute my thanks to Petros and Beatriz, and of course to Europa, to PCR, and to Medtronic for sharing this experience with all of you. I hope this has been useful, and I wish you all of you a good evening. And see you the next time. Goodbye.
Thank you very much. Thank you.
Goodbye. See you.
Thank you. Bye.